Hello, I'm Dr. Barbara Kaminski, Clinical Director of Greenbox ABA, and I will be your host for this workshop. Today, we're going to talk about how to build your child's dream team by coordinating your child's different medical and therapy service providers. If you're watching this recording, it most likely means that you are regularly interacting with multiple different professionals, such as a pediatrician, maybe a separate developmental pediatrician, an occupational therapist, a speech therapist, maybe a physical therapist or a psychologist, and of course, ABA. All these professionals are focused on that important person, your child. Not only do you have to keep straight all the different things each says and does, but somehow you need to also make sure that they are all coordinated. Because if we're not all moving in the same direction, if we're not all looking towards the same long-term goals, we can find that there are ways that we are working against each other. Or we're working on the same thing but in different ways. So how do you, as a parent, get us all to work together? Because you're really the key in this. I can't talk to another practitioner, and another practitioner can't talk to me unless you've initiated that contact and helped to bring us together. So before we talk about how, let's just step back for a minute and talk about why. First of all, we know that good communication between providers leads to the most clinically effective, timely, and cost-effective outcomes for our children. That is, good communication between providers moves things forward in the best way clinically. One of the most important reasons why you want to make sure that your providers are communicating is so that we're not working against each other or approaching a need in contradictory ways. This is especially true for the challenging behaviors that we work on in ABA. Let's look at an example. Imagine that your child runs away from the therapy area when a therapy task is presented. Your behavior analyst has developed a behavior plan, but OT doesn't know anything about the plan. In OT, whenever the child leaves the area, the therapist spends a lot of time chasing the child and convincing them to come back to work. The problem is that the behavior analyst has figured out that the child leaves the therapy area because this helps avoid a task and because the therapist changes the way they interact with the child. The behavior plan that the behavior analyst has developed involves a high level of reward for finishing tasks and for asking the therapist to better explain the task whenever the task is hard. The way that OT is acting during therapy might be literally going against what we're trying to teach in ABA. Or if a speech therapist is working on getting a child to say words in a particular way, and we are also working on communication, but in a different way. Or an OT is working on fine motor skills using a claw pencil grip. And in ABA, we ask a child to write answers, but without using a pencil grip. In those cases too, we are working in ways that will slow down progress. Another important reason to keep things coordinated is because a change in one therapy can affect response to other therapies. For example, if a pediatrician prescribes a new medication for ADHD symptoms that co-occur with autistic symptoms, that can affect how the child responds in ABA therapy. If we don't know that there has been a new medication, or a change in the dosage of a medication, or the discontinuation of a medication, just to stick with the medication example, then we may see changes in ABA therapy response and have no idea why it's happening because we haven't changed anything about our therapy. So if we haven't changed anything, where did that new behavior come from? By not knowing about the medication, by not having coordinated with the pediatrician, we don't know what to do. If a medication for ADHD was discontinued, and now we're seeing that the child really can't attend to what we're working on, can't sit, is running around, having a hard time following our directions, we may wonder what we need to do. Do we need a new behavior plan? Do we need to change therapists? When really what needs to happen is a coordination between the behavior plan and the medication changes. A third reason is because the response and effectiveness of one therapy can affect the response to another therapy. For example, a child who is learning how to control their emotions in OT may respond very differently to a behavior plan than one who is not learning about paying attention to their emotions. And your child's overall progress is a result of all the different therapies. So by sharing data and assessment results, we can see how each of our therapies are moving things forward and make adjustments as necessary. Let's look at some examples of the kind of information that could be important for a provider to share with other providers. Some things your pediatrician might know that could help other providers are things such as possible reasons for nighttime bedwetting. Maybe your child is experiencing bedwetting at night and you have asked ABA for some help. It's also really important that the pediatrician weigh in on that and explore whether, and share with other providers whether, there are medical reasons for the bedwetting. The pediatrician knows what medications your child has taken and what the effects and side effects are to a particular medication. By sharing that with us, we can evaluate whether the medication is affecting behavior. And in fact, in these cases, we can directly help evaluate the effectiveness of the medication on behavior. The pediatrician might also be able to share information about the effects of other diagnoses. So besides knowing about how autism affects your child's behavior, it's important to share other diagnoses and how they might affect behavior. We're not medical doctors, so we don't necessarily know what those effects are. Some things that an occupational therapist may know that could help other providers include whether a child is having sensory sensitivities that could make them more likely to have a meltdown. Occupational therapists have special knowledge about how a child is responding to sensory input. Being able to share information about how that input could lead to potential meltdowns can really help the other service providers with deciding how to structure sessions, what kinds of stimuli to expose the child to, and so forth. An occupational therapist could also share information about motor difficulties that might make an impact on how difficult a task is. In ABA, it's not within our scope of knowledge to know about a child's level of motor skills. So let's say that we're working on sharing by taking turns with rolling a ball back and forth. That seems like a pretty simple thing to do. But if the child has challenges with the motor skills involved, then they may not want to do that activity with us. And because we don't know about that motor difficulty, we think it's related to the skill of taking turns. Some things that a speech therapist might be able to share that would help other providers include the appropriate developmental level for instruction. The speech therapist is someone who is uniquely qualified to understand things like how long sentences should be at each age, or what the appropriate vocabulary is at each age. And they are aware of where your child falls with respect to that. So they can share that information with other providers so that we can use the right kinds of instructions, not using instructions that are too complex or too hard to understand. An SLP might also be able to help other practitioners understand the social communication deficits that are affecting social interactions. Speech therapists have social communication assessments that they conduct and have particular expertise and understanding of how people socially communicate with each other. So they can help us in ABA in particular as we develop the social interaction goals, sharing both what is appropriate for the developmental level and for your individual child. Of course, there are some things that an ABA provider might know that can help your other providers. For example, if there is a challenging behavior that's occurring, a child is aggressive or won't follow directions or tries to leave the room when something is asked of them, things like that. Part of our job is figuring out why those things are occurring And once we figured out why those things are occurring, we can share that information with other providers so they can work with your child on things in a way that is the most effective. We can provide other providers with strategies for increasing engagement with treatment. We can help them to understand how to arrange their therapeutic environment for a particular child so that the child is more happy, relaxed, and engaged in the treatment that they receive, whether that's speech or OT or physical therapy or something else. That was a lot of information to digest on the why your child's providers should communicate with each other. Hopefully, I've made the case to you that it's really important for all of us to be talking to each other as providers, and that when we do, it helps your child move forward most successfully in all the different kinds of therapies. To help you understand what to expect from coordination, let's talk about what kinds of information your providers can share. With your permission, because your permission is required, in order for us to share, we can share such things as treatment plans and the treatment goals that we're working on. And once we've shared the treatment plan, we can share treatment progress in the goals and can update other providers on how the child is responding to the things that we're working on, that is, on the kinds of progress that we're seeing. We can share any kinds of safety plans. So if in ABA we develop a plan that involves how to respond to behaviors that pose a risk to the child or others, we can share that with other providers. We can share response to medication and medication changes. So if a pediatrician prescribes a particular kind of medication, and then in ABA we intentionally measure the child's reaction to that medication, we can share that information back to the pediatrician. By the way, that is a very useful thing that we can do. We can very systematically collect information on how your child's behavior changes in response to a medication and share that information not just to you, but also back to the pediatrician to help the pediatrician make the best decisions about whether it is the right medication or whether it's the right dose of that medication or whether this medication should be continued or modified. We can share with each other strategies on what we have found that works best for your child. Maybe we know that your child works best if they are given a break every 10 minutes. Or the OT knows that your child loves to play with shaving cream when working on goals. Other practitioners could then use shaving cream play as a reward or use it in our tasks. We can share with each other those kinds of strategies, those things that have been successful in one therapy that we can move around to other therapies. Finally, we can share general observations about treatment effectiveness. All right, so how can your practitioners share with each other? This is, I think, what you are most interested in knowing about. If you're here, that means that you want your practitioners to be sharing with each other. I do have to admit that there are some limitations and some obstacles to sharing between practitioners, but I'm also going to share some strategies with you to overcome the obstacles. Let's start with the limitations and obstacles that we face when sharing and coordinating with each other. The first of those things are the HIPAA regulations that protect medical information. One of the things that every practitioner has to do is to adhere to protecting the medical information related to a person's medical records. Fortunately, all that's really needed in order for practitioners to share with each other is a release. So if you give written permission to one practitioner to speak with or share information to another practitioner, then we are allowed to share your protected health information with each other. The other place where HIPAA regulations come into play, however, is that practitioners have to make sure to use HIPAA compliant methods for their information transfer. So if a practitioner doesn't have a HIPAA compliant way of sharing documents electronically, that can be a limitation, and it is something that has to be figured out. The second limitation that I would like to talk with you about is our insurance payer restrictions. Most insurance companies have some restrictions on what kinds of services are covered by insurance. One of the most important of those is that in most cases, insurance does not allow for simultaneous services by two providers. So, for example, if you requested that one practitioner meet with or watch your child in a therapy session being provided by another provider, only one of those two practitioners are providing a covered service at that time. It is very important that the need for the observation be very clearly defined and agreed to by both providers. And if there is a more efficient way to share information, the provider should choose that option. If the concern is that your child does not participate in speech or OT sessions with the same level of cooperation as ABA, the solution may not be for the ABA therapist to go to speech or OT to see how the therapist works and then give suggestions, but for the OT or speech therapist to observe how the ABA therapist works and copy what we do. And we can then give them some advice and feedback after they have watched us. The second thing related to insurance restrictions is that each provider needs to remain within the scope of practice. If you ask us to coordinate with an OT who is working on handwriting, we can make sure that we use the same techniques as the OT, but we cannot have a handwriting goal because handwriting does not fall within the scope of practice of behavior analysis. There are some things that we do within ABA that may incorporate motor skills or speech production skills. For example, if there are behavioral problems that happen while we're working on handwriting, we can work on handwriting in that context, but we can't work on handwriting from a mechanical perspective, just how the child responds behaviorally when asked to do handwriting. We have to make sure that we're working on the right things according to what the insurance company is looking for a particular specialty to be working on. Another obstacle is simply provider availability to be able to work with each other. Most providers have sessions back to back to back, so there are very few gaps in their day. And if there are very few gaps in your day, that makes it very difficult to find the time to talk to another related service provider. So sometimes, while we may really want to talk with each other and have the best intentions about coordinating, literally our schedules just do not mesh. I'll talk in a minute about some of the ways that we can get around those schedule problems. The most troubling obstacle is lack of provider willingness to collaborate with other providers. There are times when a provider doesn't acknowledge the benefits of another therapy. They may have had a previous bad experience working with someone from that specialty, and as a result, not see the benefit. They may consider the other therapy invalid or ineffective or unnecessary, and when that's the case, then they're not very willing to work in a collaborative way with that other therapy. They may have respect for the other therapy, but not believe that the other therapist has valuable information to share with them. They may not see how the therapies interact. The other limitations that I've talked about have mainly been logistical and technical kinds of things. But this is a very different kind of limitation and a much, much more difficult hurdle. It's a different kind of obstacle to overcome. So what can be done? You don't really have the power to change a provider's perspective or beliefs about another therapy. I wish I had a really good answer to this obstacle. We do have a handout that you can share with other providers about ABA therapy and the way that we can work with related providers. And I will always make us available to help you in that respect. So for example, if you're having difficulty with a speech therapist or an occupational therapist or your pediatrician or whoever, if they're giving pushback about talking with us, we are always willing to talk with you about some of the ways that you can overcome that obstacle. I could give you some blanket statements to use, but it really comes down to a conversation so that we can figure out why we think that practitioner isn't willing to collaborate. And then once we have some understanding of why, then we can start to develop some strategies for how to get over that particular obstacle. Finally, I do want to point out here, however, that our ABA providers should only be collaborating with reputable services. This includes OT, speech, PT, feeding therapy, psychologists, psychiatrists, pediatricians, and developmental pediatricians. Basically, any service that is also included in insurance coverage. There are therapies that promote themselves as miracle cures, but are mostly unproven or are potentially even harmful. Please understand that practitioners, not just ABA, but other practitioners that I've listed, may be hesitant to work collaboratively with those therapies, but we would be happy to talk with you about some of the reasons for our reservations. All right, what about those other obstacles? The ones based on logistics and restrictions from insurance requirements. How can we deal with those? The easiest thing that we can do is share documentation. Treatment plans, progress reports, assessment results, they can all be shared. These documents give the practitioner easy access to information about what is being worked on in the therapy sessions and the progress that is being made. Such documents are also easy to refer back to later, and all of your practitioners are required to keep documentation of treatment. For us to share documentation to another provider, all that is needed is for you to request that we do so and fill out a release of medical information form, which the office can send you through DocuSign. Sometimes things in the documentation need some clarification, or it would be good for two practitioners to talk through some issues together. We can do phone consultations or remote meetings, for example, through Zoom. For those phone calls and meetings to be most effective, it is best to first share some documentation like the treatment plans. If we have seen each other's treatment plans, then the conversation can be more targeted. I noticed you were working on blank. Can you tell me a little bit more about how you're working on blank and how that's progressing and what kinds of strategies you have found that make that really effective? That's a much more targeted conversation than just, tell me about what you're working on right now. So I recommend that you first ask your practitioners to share documents with each other, and then, if needed, follow that up with a phone call or a Zoom consultation. Your providers can also use HIPAA-compliant email exchanges in which they have conversation, but through email. Because email is not dependent on coordinating schedules, this can eliminate a lot of the logistical problems. Observation of other therapy sessions can happen in limited and special circumstances. For example, another provider may be having difficulty with challenging behavior during sessions and like some input from ABA. After reviewing our behavior plans in a Zoom meeting, the other provider may still be having a hard time implementing the same behavior plan. In such a case, it might be appropriate for either ABA to observe the other therapy session or the other provider to observe an ABA session so that we can model for them how to implement the plan. An alternative to either therapist physically going to the therapy session is to give your providers permission to videotape and share the videotape, again, in a HIPAA-compliant way. I understand that some people have hesitation about therapists making and sharing videos, and that has to be your carefully arrived at decision, but it is an option. All right, so we've talked about why it is important for providers to be coordinated, what kinds of information can be shared, and through what kinds of formats, what some of the obstacles are, and how we could overcome those obstacles. But none of that happens until you've actually connected people to each other. So how do you connect your providers? The first thing I want to remind you of is the importance of understanding the strength of each type of provider and what they can work on. I mention this so that you can have realistic expectations. Coordinating providers in order to build a dream team is one thing. Expecting a provider to work on things that are outside of their specialty or to pass judgment on the treatment being provided by another specialty is not a realistic expectation. It's not unusual for a parent to ask me a question like, how do I know which therapy would teach my child the best? I know that it can be very difficult to know what is appropriate for each provider to focus on and to evaluate whether progress is being made in each therapy. It is difficult for us to evaluate progress being made in other therapies that are using different methods of evaluation, but we are always happy to discuss this with you individually and try to give you the tools to evaluate and make your own judgments about progress in both other therapies and in our own. At the very least, we would need to have documentation from the other providers to use as a basis for the discussion. To begin the process of coordination, you should talk to each provider that you would like to coordinate with about coordination of care. Talk to your behavior analyst and let them know that you would like them to coordinate with your other providers. Have the same talk with the other providers. Share the names of your providers. We have created an info sheet that you can share with your other providers that outlines the benefits of care coordination. It leads through some of the things that we talked about today and includes information about what is applied behavior analysis and why we should coordinate with each other and how and what to share. There is a section at the bottom that can be filled out with ABA provider information. You can get this info sheet from the office, from your behavior analyst, or you can download it yourself from the parent section of the website. Start with sharing documentation. As I already mentioned, we have a form that you can use to request the release of medical information and to give permission for personal contact and observations. The office can send you this form and coordinate this between you and your behavior analyst. Be sure to authorize sharing documentation, but also give permission for contact so that the providers can follow up as needed. Your other providers should have a similar document that you will also need to complete, allowing sharing of information about that therapy. I suggest requesting a follow-up from each provider about the outcome of any communication. So after we've shared information and after we've talked with each other, then go back to each of us and say, so how did that go? What did you learn from each other? How are you coordinating? And did you figure out the best way to work on this together? Continue to follow up with both providers. I would really love to tell you that it doesn't become your responsibility to make sure that they stay coordinated, but in reality it does. You will likely have to just ping each provider occasionally. And I recommend that you ask your providers about setting up regular check-ins. For example, after each treatment plan update, or if there is a new behavior plan in ABA, remind the provider to share it to the other approved providers. And let those providers know to expect it. If the permission is already in place, then this will be as simple as the BCBA asking the office to share the document. At that time, remind both providers that they can follow up on the documentation with a phone call or a Zoom call. Because your related service providers don't all meet in the same room, as is true for a school IEP team, it takes a little bit more work to keep them communicating. But I hope that you've learned some things today about why that is important and some strategies for how to make that coordination happen.